is the perinatal committee and the under 5 committee to allow us some insights about what they've done over the last year and some of their progress and some of the areas where they haven't succeeded. Usually we give them quite a substantial slot, 20 minutes each, but we don't have that luxury today. So we've got 2 speakers. We've got the head of the perinatal committee, people know Natasha Rhoda, and we've got Neil McKerrow. Neil, you're not coming up. Okay.
It's coming off.
All right. The problem, however, is they've got 15 minutes, so they've got 7 minutes each. And if anyone knows either Natasha or Neil, you know that to try and contain them is impossible. So Natasha, 7 minutes, 8 minutes for you. Neil, 7 minutes for you. No, 7 minutes each with 1 minute in between. But please take the stage. Thanks, Natasha.
Thanks for the generous allocation of time. And welcome to Cape Town, everybody. I think I saw most of you last year in KZN. And in those 7 or 8 minutes, I'm going to try just to home in. To Gabriel, I wanted to say that we are the committee for the voiceless. And unfortunately, everybody's managed well. I suppose fortunately, everyone so far has managed to stay away from the facts. But those voiceless, every year, for our committee, amount to about 30,000 deaths. Those are 30,000 perinatal deaths, on average 20,000 stillbirths, mothers who are pregnant who don't actually give birth to a live birth, and 10,000 neonatal deaths. So that's the setting. So sorry if I've changed the mood, but I thought we have to get a little bit real. So in the 7 minutes, I might not get through all this. I will provide this talk to you. I specifically will not be able to get through the involvement of the DCSTs, and I know a lot in the audience, there are some very good DCST pediatricians and nurses here, specifically for neonatal and pediatric health, but you're welcome to look at the slides afterwards and we can discuss quality of care indicators. But I'll try to go through most of this, but the good news for the 2016 update from NaPEMMCo is really our focus on asphyxial deaths, and I'll spend some more time on that. So you've heard the UNICEF colleagues of ours talking about SDG. MDG has come and gone. We're going now for SDG. We've got 15 years. And we need to get to a target for neonatal mortality rate of 12 per 1,000 live births, and for stillbirths at about 12 per 1,000 total births. And for South Africa, our Minister of Health has gone to the UN and has already said we are going to achieve that. So, yay. But he's also added something quite interesting, and I've just come back from the International Conference for KMC, and what he said, and it's in black and white, he said, all facilities in South Africa will provide good quality kangaroo mother care. So kangaroo mother care, for those of you who don't know, is where you put your baby skin to skin. So well done. And you've also heard he's spoken about the other major thing, which is breastfeeding. So yay to the minister. So in 2016, what has changed? Well, unfortunately, the burden of disease hasn't, and certainly not the causes, the top 3 causes for death, which is asphyxia, A, prematurity, P, and I, infection, which we've encapsulated in a strategy about 4 or 5 years ago called happiness, which you must have heard of, because there are lots of interventions that are connected to the happiness strategy. And I want you to look at the second half of the slide, which talks about the preventable or avoidable deaths. This is our own data, so unless we're lying, most of them are avoidable. Look at those numbers, they're in excess of 50%. So of those 30,000, 25, 26,000, 20,000, even if you take half of it, 15,000 preventable. So in 2012, NaPEMMCo had put together the happiness strategy, focusing on the 3 priorities for death: asphyxia, prematurity, infection. We then linked that and integrated it to interventions that cost money and for implementation, which is where our Achilles heel is at the moment. But you know about helping babies breathe, which was started in October 2013. Secondly, then management of the small and sick, which was an essential package, comprehensive package for neonatal care, which started in September 2014. And we've managed to provincially capacitate master trainers for all the provinces from the National Department of Health. The last one there you see is CPAP, and some of you will have been recipients of phase 1, and now we're in phase 2 of providing CPAP to the areas where it's most needed, where there are a lot of premature births and subsequently hyaline membrane disease. These, as you can see, are all in keeping with international recommendations. One is from the UN in 2012, and subsequently we've also been recommendations from the Lancet. So we're not thumb-sucking, we know what we're talking about. So integration is really the buzzword globally, not only integration across the continuum of care for maternal and neonatal, but now also for child health. And the South African government, which Nonhlanhla hasn't told you, now has an integrated plan for maternal, neonatal, and child health. And you can see we're sitting there in the middle between the mother and the child, where we should be focusing on asphyxia, prematurity, and infection, with enablers within the health system clearly demarcated. So what about the numbers? These are our data systems. We have the national data system, the district health system, which gives you the numbers, the absolute numbers of births and deaths. The perinatal problem identification program, which is PIP, allows you to see why babies are dying. So why are those fetuses dying, and why are those neonates dying? But you spoke about data, Nonhlanhla. We still have data gaps. So it's really difficult to plan if you've got massive data gaps. So you might have the numbers, but you don't know what the causes of the deaths are, why they are dying, what the avoidable issues are. And you can see the provinces that have huge data gaps. And we're trying, and you see this was extracted from PIP in October 2016, so about a month ago. So it's still the truth. So let's go to what we track, which are so these are in facilities. So DHIS is only in the government hospitals, where the majority of the births in South Africa happen anyway, just under 1 million. And these are the provincial trends from 2010 to 2015. And you can see as South Africa, we are somewhere between 11 and 13. And there are interprovincial differences. So if you remember the target for SDG in 2030, in 15 years' time, it was 12. So a lot of people think we can, fold our arms. And that's why it's important not to look so much at the rate, but specifically to know that every newborn counts, and I've told you those numbers. Perinatal deaths, 30,000 a year. We do the same for stillbirths, so you can follow the same. On average, somewhere between 20 and 22. This was extracted in May when the DHIS was closed, and there are interprovincial differences. So if you go according to the color system, green, yellow, orange, and red, you can see one province has managed for neonatal mortality rate to get to under 10. This is a graphic representation. There are downward trends, interprovincial changes, but a bit difficult to go through this slide in the time, so I'm going to skip it. So what about the good news for 2016? Certainly from our perspective, since we've done the recommendation in 2012, and we've sat for the last 2-3 years trying to get the interventions going, capacitating the provinces with master trainers for HPB and MSSN, we also know that asphyxia, even though premature deaths are more than asphyxial deaths, the asphyxial deaths are more than 95% in big babies. So these are mothers that get very close to, get to term, deliver a baby, and then the baby has an insult. Okay? So that is really a problem for us. So these are really avoidable deaths. And if you look at the statistics, those mothers, so these are the asphyxial deaths in babies more than 1 kilogram. So we're not looking at those tiny tots. These are the bigger babies. You can see that 80% of these have been coded as having an avoidable cause. And that's the biggest problem. We are analyzing most of these deaths, so it's not a problem in a data gap. And if you then go down, right down into the provinces, what I've put for you in green are the percentage avoidable deaths for asphyxial deaths more than 1 kilogram. So that's a big worry. So these shouldn't be happening. But more importantly, this slide is quite significantly important. If you look at this, most of these mothers are actually healthy. There's a small percentage where the death is associated with hypertension that was missed, etc. But these are actually healthy mothers that we ask, come to do your antenatal bookings 8 or 6 or 7 or whatever they are. Well, they're 8 or 9 now, aren't they, for Bank Plus. But these are actually healthy moms. So a healthy mom and then getting an asphyxic neonate, it's a real worry and a shame. Just to say that we haven't just stopped at the S part, which is the survive part. We also want to plan ahead because, after all, we are a committee for perinatal deaths. And me being a baby doctor, we've concentrated quite a bit on the neonatal deaths. The upstream factors for the stillbirths are also on our agenda. And as we did a plan 2 or 3 years ago, a national neonatal plan, we are now in the process also of completing our stillbirth plan. We had hoped it could come out with the WHO launch, which was this month. Or last month in November, but unfortunately there was a delay, and we should be ready by February 2017 to have a strategy nationally to take care of stillbirths. This is clearly, obviously, in conjunction with the maternal side or committee, which is the NCCMMD. And just to say, when you spoke about the DHIS, we've also, as a committee, had a meeting with the DHIS people. And in order for us to track the indicators, we can't just have gross things like neonatal mortality. We want to know coverage. So there are lots of every newborn action plan, or ENAP indicators, of which there are 10, which we now want to include in the neonatal register as data elements so that we can track them for the country. So those would include morbidity data elements. So we are a committee of mortality and morbidity, and also coverage of KMC and helping babies breathe, etc. Okay, so our recommendation for this year, just a month ago, which was October, the NHC has now accepted the focus of asphyxial deaths. So we said there are lots of reasons why babies are dying. The biggest amount that we should be concentrating on are those healthy mothers who are having 80% asphyxial deaths for their babies. That's the problem. So we should be focusing on that. And that was actually a 2015 recommendation, which has now been signed off. So we're hoping going forward for the next 3 to 5 years that we are going to get funding for implementation thereof. The other things I've spoken about really is to ensure that we keep our DCSTs. They have been a phenomenal part of the team for primary health engineering, and they are amongst you here. I see quite a few faces I know. They've done an amazing job, and we should keep them. And just to the DCSTs, don't forget, you can look at your impact indicators such as NMR, but don't forget that while you're working, the quality of care indicators is a good way of looking if you're going in the right track with all your interventions. Okay, so how are we going to reduce these asphyxial deaths? Well, we've got a plan over 3 years, and this is per facility for all the asphyxial deaths, and we've got them in absolute numbers. We will be reducing them thus, in conjunction with the maternal side, specifically looking at the Safe Childbirth Program, which is now new, which includes safe cesarean section, respectful care, and maternity units for human resources. You can read the others. The other issue is just to know that Bank Plus is on its way as well, which is now 8 visits, and you've heard the last 2 weekly from 36 weeks onwards. We need to get coverage for our interventions. I've told you about that. And the last slide now is trying to get, implementation doesn't happen if you don't have resources, both human and financial. And so we have approached as a 3 ministerial committees, Neil, myself, and Jack Moodley from the maternal side, to get funding to allow for us to implement all these good plans. Because at the moment, that's what they are, good plans, but they're not implemented and we're not seeing the change. Whew, how's that?
How the hell do we get out of the now we want to... Okay. I think Haroon is obviously getting old, because he let Natasha take my 7 minutes. So you now have to listen fast. Okay. This is the current data on under 5 mortality. I've put up 2 figures, the MRC data as well as the CoMMiC data, because they're slightly different. They take the same raw original source, which is vital registration. MRC corrects for underreporting of deaths, but CoMMiC does not correct. We believe we need to show you the data as it exists so that you can challenge it when it doesn't represent what you believe your services are delivered, and then you go back and make sure that we get the correct data. Until you do that, we're going to present you with the data as she is. All right. This is the raw figures underlying all of that, and I want you to look at 2 columns. The very first row, which just shows you the number of births registered has remained just over 1 million, and we know that's under registration because there are about 12, not 12,000, I'm like the president, 1 million, okay. There are about 1.2 million births in the country, but just over 1 million are registered. And then if you look at under 5, the 4th row from the bottom, you'll see that the actual number of children dying
whose deaths are registered has dropped quite substantially over the past 5 to 6 years. If we break it down to a provincial level, all I want you to appreciate from this slide as you listen fast is two things. There is a tailoring off of the decline in under 5 mortality. From 2007, there was a rapid decline, but from 2012, the number of deaths or the rate of decline has plateaued out quite markedly, and we need to strengthen existing programs, not create new programs to achieve that. And the second thing I want you to pick up from this is inequality. There's a threefold difference between the province with the lowest mortality, and that's KwaZulu-Natal because the Western Cape is a different country, and the province with the highest mortality. So there's a threefold difference at the provincial level, and if you unpack it and disaggregate it to the district level, that difference is tenfold between the district with the lowest under 5 mortality and the district with the highest. To give you the district data, this is it. Now, first column is neonatal according to vital registration. So it's a little bit different to what Natasha has shown you. Then we've got infant mortality, then we've got under 5. Then we've got data that shows us what proportion of these deaths are occurring within the health sector. So country as a whole, 48% of children who die in the first 5 years of life do so within the health system. 52% are dying outside the health service. And some of these have entered the health system, being discouraged by the care. 1 or 2 may have been sent home to die. And we know that this data is incomplete, particularly in KwaZulu-Natal and the Eastern Cape, where, according to the community survey, at least 50% of deaths in the community are non-registered. Then we have the contribution of malnutrition to under 5 mortality. So 31% of children who die in our health service are severely malnourished. If we include moderate malnutrition, it goes up to 60%. HIV, big improvement here. 35% of children who die do so in association with HIV. They are infected, or we don't know what their status is. They died before that was established, but we know mom was HIV infected. 32% of children die within the first 24 hours of entering the hospitals, not the health service, and case fatality rates have dropped quite markedly over the past few years. The actual causes of death, ill-defined is high. 15% of the deaths are ill-defined in terms of causation, and this really reflects what is happening with the community deaths, where we are given a symptom rather than a diagnosis. So if we remove that, neonates contribute substantially. 1/4 of the deaths are due to neonatal causes, pneumonia, diarrhea, and I want you to pick up non-natural. If we take the age group 1 year to 4 years, 18.5% of those children die from a non-natural cause. Motor vehicle accidents, poisonings, drownings, electrocution from illegal electricity connections. So when Eskom raises the rate, illegal connections increase and more children die. If we then look at the underlying factors, this is just to show you the trend, and I want you to recognize the contribution of HIV has declined quite markedly. That of severe malnutrition hasn't changed over the past 6 years. Neither has the proportion dying in the health service or the proportion dying soon after admission. But our case fatality rates in hospital have improved quite markedly. When we interrogate the deaths, this is from child PIP data, and you can look at it if you can see it from the back. That teaches you to sit at the back. And if you can't, there are basically 3 themes you need to be aware of. The first is record keeping. Our record keeping is poor, from recording in the Road to Health booklet, referral letters, documentation in our hospitals, poor. And that plays a huge role when we look at medico-legal litigation. Second theme is malnutrition. Poor household food security, poor growth monitoring, poor supplementation of children failing to thrive, and late referral of children with malnutrition, and poor implementation of WHO 10 steps for those children admitted to hospitals. And the third theme is emergency care. Failure to appreciate how sick the child is, then delayed entry into the health service, failure to assess and treat effectively at the clinics using Walter's IMCI program, and at hospitals, failure to adequately assess, triage, and treat children who arrive critically ill. So those are the three themes: nutrition, record keeping, and emergency care. So looking at all of that, we've got a whole list of recommendations, but the priority recommendations at the moment are non-rotation of staff, because if they don't rotate, we can capacitate them and they have the chance to actually implement what they have learnt. If they rotate, we're forever training and never implementing. Second is the development of an essential package of care for children, which really is the framework on which we can deliver a whole variety of targeted programs. Then the first 1,000 days, early child development, really effective implementation of the Road to Health booklet as the standard record of a child's health care. It's a phenomenal tool that is very poorly used. Promotion, prevention, the support of the sick child, and it is being restructured. Same information, new format, which hopefully will come out next year. And then finally, support for frontline healthcare workers through outreach programs from the level above them. So tertiary to regional, regional to district, district to community health center, primary healthcare clinics, and the clinics to the household. So to recap, 1 in 29 children in this country will die before their 5th birthday. It's an improvement from the 1 in 20 5 years ago. We've saved about 70,000 deaths in the past 5 years, but neonates remain a problem, deaths in the community remain a problem, and in the health service, children arrive late, how we treat them on arrival is poor, we don't have the ability to review them when they deteriorate, we can't care for them in our district hospitals, we don't have access to high care services, so the critically ill children are not adequately catered for, and those problems I've already highlighted. And just for your information, these are the members of the committee, and you will see we've got a high attrition rate. So we are looking, we've just replaced most of those, so we're back to full strength, so we will continue to tell you what to do. Thank you very much.
Thank you, Neil, and Natasha, for fast-forwarding through your presentations. We've now got a very clear picture of what the